And there we go. So before we get started, like I said, please introduce yourself in the chat. We would love to know who's joining us today for our talk story session, our fairly informal talk story with some great updates from Dr. Vivian Huang from Dynavax Technologies. But first, before we get started, I just want to mahalo all the folks who are involved in putting this together. So mahalo to the University of Hawaii Cancer Center, the Hawaii Comprehensive Cancer Coalition, Hawaii Immunization Coalition, and Dynavax Technologies. This is really a community effort to push this forward and to really ensure that our communities are protected and stay healthy. So really thank you everyone who's involved in this today. To give you a little bit of an idea of what's going to happen today, I'm just going to walk us through briefly. Again, please introduce yourself in the chat. We would love to know who's joining us today so we can better address your questions and needs. I'll provide a little bit of context, and then we're going to talk about opportunities with Dr. Huang. Joanne Amberg, our certified nurse midwife from Kalihi Valley, is going to share some local perspectives, and then we'll open it up to you folks for questions and answer. As you might recall, being on a Zoom, we just ask that you folks mute yourself when you're not speaking, or we might just click on the mute for you. And if you have questions or anything, feel free to put it in the chat or raise your hand. So at this point, I'm just going to see if there's any questions or comments folks have already. All right. And thank you, Judy, for introducing yourself in the chat. Again, if you could do that as well, folks, we would love to hear who's joining us today. So I'm going to move forward and just give you a little bit of context before we talk about the opportunities. So this is brought together through our coalition of coalitions, right? So many of the folks that I had mentioned are part of our Hep-Free Hawaii coalition, which is now 10 years old. So we're entering tweenhood. We started this about 10 years ago, and this is the strategy that our community came up with over 1 year during COVID, talking with over 160 people, over 25 formal meetings, not including informal meetings, to really address the needs for our local folks. This is our mission and vision, but I always want to reiterate our values and practice. And we restate this anytime there's a Hep-Free Hawaii meeting or a Hep-Free Hawaii event. So we hope that when you are engaged in this session today, that you recall that we are rooted in the values of harm reduction, so non-judgmental, community and client-centered, and really celebrating any positive change. Social justice, so acknowledging that our work in health is also work in justice and also addresses larger social issues. And of course, that ties in with intersectionality, so that when we talk about hepatitis immunizations, we're also talking about immigrant-migrant healthcare rights, and we're talking about language access, and we're talking about a host of other issues that are tied in with hepatitis. And finally, we acknowledge the value of aloha. So not only love and community and all the nuances of that word, but acknowledging the place and the people in which we work and with whom we work. So those are the 4 values. Just want to reiterate that so that we can move forward. These are the 5 priorities that Hep-Free Hawaii has acknowledged as the priorities for eliminating hepatitis in the next 8 years. And so that includes awareness and education, which you're kind of doing right now, access to services, and we'll talk about immunizations, advocacy at all levels, equity in everything we do, and data for decision making. So to give you that kind of context, I'm going to drill down a little bit and just note that one of the priority areas is access to services. And one of those, as you can see, is immunizations, which is really why this aligns with our work in the coalition. I'll also acknowledge, I see Christina Teal has joined us, that this kind of overlaps with our previous state cancer plan from 2016 to 2020, which includes a specific mention of hepatitis B immunizations. And this one is specifically for community pharmacies, but of course we work with adult immunizations in all settings. So just really showing that this has been an acknowledged and important issue for many of our communities working in public health. So to give you a little bit of local context in terms of what's happening in Hawaii, we'll just note that unfortunately, we don't have robust hepatitis B surveillance, but we do know things are happening. So we do know that according to the data from our liver transplant center, that hepatitis B and C account for 2 out of 3 liver cancer cases in Hawaii. And that liver cancer is really high in Hawaii. We actually used to be the state with the highest rate of liver cancer incidence and mortality. Luckily, I think we're down at around number 8 or 9 now, which shows some progress, hopefully, in terms of the work that we're doing, especially with our coalition members. These are just some of the communities that are affected by the vaccine-preventable hepatitis. So I'll acknowledge that hepatitis A affects our people who are houseless. It's about 6,400 people in 2020 that could be affected. Of course, our sexual and gender minorities. So this usually is colloquially known as the LGBTQIA+ community. Are also more likely to be affected by viral hepatitis A and B. And of course, our communities who are Asian Pacific Islander, and I'll also note African, especially if they're born outside of the US. So just to kind of acknowledge is not to stigmatize these communities, but to really have us think that these are the community members, these are the people that we know and love and work with. And so how can we continue to protect our communities that we're a part of? I'm just going to briefly just show you some data. So this is data from our Hawaii Behavior Risk Factor Surveillance System, or BRFIS. This is self-reported adults in Hawaii. You can see it's from 2017 to 2019. This is just showing the adults who in this survey reported completing the 3-dose vaccine series. So you could see here kind of averages around 50% if we were going to kind of combine them, a little over around 58%, but really there's a lot more work to be done, especially given the new recommendation that all adults aged 19 to 59 should be vaccinated for hepatitis B, which Vivian will go over actually during her presentation. So I'm just going to stop here real quick. It is a talk story, and we really appreciate everyone sharing their interest in the chat, but any questions or comments so far, feel free to raise your hand or put comments in the chat before we move forward. All right, so I'm going to stop sharing and hand it over to my colleague and fellow hepatitis B champion, Dr. Vivian Huang. So go ahead, Vivian.
Hi there, everybody. Can you hear me okay?
Yeah, we can hear you. And then it's in the presenter mode.
Let me just give me 1 second here to get it into, let's see.
And then Vivian, the bottom right has a, oh, there you go.
Hold on 1 second.
Awesome. And while Vivian works on that, if you folks haven't already, please introduce yourself in the chat so we can see who's with us today. So thanks, everybody.
I'm trying to get to the top here to make it so it's in presenter mode. Let me see here. It's
Vivian, on the bottom right, along that kind of bottom right, those icons where you can see, like it says 47% along there. That icon, one of those is the screen, full screen. There you go.
Perfect. Okay, sorry about that. So good afternoon, everybody. And thank you, Thaddeus, for that. Really excited today to be able to present to all of you on a topic that's really near and dear to my heart. Unfortunately, hepatitis B has affected myself and my family, and so I've known about hepatitis B since a very young age. And it's also really one of the reasons why I went to medical school. And so again, my name is Vivian Huang, and I am a regional medical director in the Medical Affairs Unit at Dynavax. I cover the West region, which includes 13 states and includes Hawaii. So my talk today will be about hepatitis B and also recent updates in adult Hep B vaccinations. So this will be the roadmap of the topics I will discuss today. And first, I'll talk about the current state of hepatitis B in the US. Trying to see if I can find the pointer here. Okay, no pointer. And then I will talk about the recent ACIP recommendations for universal adult Hep B vaccination for ages 19 to 59. Then I will talk about co-administration of adult vaccines. And then we'll shift gears a little bit and talk about Heplessav, which is a 2-dose, 1-month adult Hep B vaccine. Then I will talk a little bit about series completion rates. And then finally, I will wrap up with conclusions and then take any comments or questions you may all have. Let me see if I can find the pointer. Let me see here. Are you able to see my mouse at all?
Yeah, we can see your mouse.
Perfect, great. Okay, so what's the current state of Hep B in the US? Well, unfortunately, hepatitis B is on the rise, and it remains a significant public health and clinical burden in the US. We know that over 12 million Americans have been infected with hepatitis B, and it's estimated up to 2.4 million are living with chronic infection. So we also know that about 80% of people that are infected with chronic hepatitis B don't know they are infected. And so they may be asymptomatic or have mild illness, which means that they can unknowingly pass this infection on to others. We also know that the estimated new cases of Hep B in the US have increased 11% in a recent 5-year period. And as you all may know, hepatitis B infections have increased over 114% in recent years in some states like Tennessee, Kentucky, West Virginia, due to the ongoing opioid and injection drug use crisis. So now let's continue to look at more hepatitis B epidemiology. So this figure here is taken directly from the CDC site and shows the number of new acute Hep B cases per 100,000 by age groups for the last 15 years from 2004 to 2019. Now I want to focus your attention on the slide to the dark green line, to the pink line, and to the red line. This dark green line represents those between ages 40 to 49. The pink line represents those persons ages 50 to 59. And then the red line here represents those ages 60 and over. So focusing on the recent last 10 years, starting at 2012, you can see that with these older age groups, persons born before 1991, the number of acute Hep B cases are either increasing or have plateaued. So this demonstrates that acute hepatitis B infections have recently been occurring more frequently in age groups that were not routinely receiving Hep B vaccines. So let's look at what efforts have been made to decrease Hep B infections in the US. Well, ACIP has long recommended Hep B vaccinations, and since the introduction of routine Hep B vaccinations in infants starting in 1991, acute Hep B infections have declined tremendously in those persons born after 1991. And that has really been a tremendous public health success. However, though, in persons born before 1991, older folks, ages 30 and older, progress has really stalled. And we have seen increasing cases in the recent years. So as a strategy to work on this, the US government developed the viral hepatitis plan and subsequent implementation considerations. These are really focused on hepatitis B elimination. These specific steps focused on elimination were really the impetus for the ACIP to re-examine the vaccination recommendations, and with an emphasis on better implementation. So how do we make sure that improving Hep B vaccination rates among high-risk adults can happen? So the thing is that we have hit a plateau using the risk-based recommendations. And so the ACIP discussed ways to increase vaccine uptake among different adult groups. And we'll talk more about this new expanded adult Hep B vaccination recommendation in the next few slides. And just for a mental placeholder, now that we have these new expanded recommendations, which are now official, the real work really begins in implementing them. Implementing these new vaccine recommendations is not going to be a small feat. So as we go through this presentation, some things to think about when it comes to implementation include: 1, focusing on addressing health equity barriers; 2, identifying best practices and applying learnings from other adult vaccination implementation projects; and 3, really thinking about infrastructure, funding, and support. Okay, so now let's look at the new expanded Hep B vaccination recommendations. Now, if you look at the left over here, you can see that the existing at-risk recommendations for adults to get Hep B vaccinations. And if you look at this bubble, there's really a lot going on here. There's more than 15 different recommendations. And one of the biggest challenges we have seen with the risk-based strategy in vaccinating patients is that it involves actually identifying these high-risk patients. And also, busy healthcare providers may not be able to recall all these recommendations. And some of these recommendations can involve really complicated dialogue with a lot of back and forth, and at times patients not wanting to tell their healthcare provider about some of these underlying risk factors, things like intravenous drug use or some other sexual behaviors, as these behaviors can be stigmatizing. So these new vaccine recommendations here in the right bubble and highlighted in yellow really simplify and streamline these vaccine recommendations. So in adults ages 19 to 59 years of age, there's now no need to walk through any of these risk-based vaccination recommendation strategies. This is a universal vaccination program where all adults previously unvaccinated for hepatitis B should now receive a hepatitis B vaccination series. Now, for adults 60 years of age and older, it's a little bit more complicated, although there are some expanded access pieces here. So the first is that those high-risk recommendations for those persons ages 60 and older do still remain. So those patients with high-risk underlying medical conditions or other risk factors should receive a Hep B vaccination series. But additionally, adults 60 and older without any known risk factors may now receive a hepatitis B vaccination series. So this results in an expanded universal vaccination program, and this unanimous vote, 15-0, occurred on November 3rd of last year. And these 3 new expanded adult vaccination policies were included in the 2022 ACIP adult immunization schedule, which was released a month ago. And just to summarize the recommendations, this includes all adults 19 years of age previously unvaccinated for hepatitis B should receive Hep B vaccination. Adults 60 years and older with risk factors for hepatitis B should receive Hep B vaccination. And third, adults 60 years and older without known risk factors for hepatitis B may receive hepatitis B vaccination. Now, one other thing to note is that during the November 3rd ACIP meeting, the 2022 ACIP adult immunization schedule was also approved. And for the 2022 adult schedule, this newly expanded ACIP adult hepatitis B vaccination recommendation is included. The 2022 adult schedule includes not only adult Hep B vaccination recommendations, but also all other routine adult vaccination recommendations. And as some of you who work in vaccines know, this 2022 adult schedule was published on February 17, 2022. And it makes these new expanded adult Hep B recommendations now official. This 2022 adult immunization schedule, however, is different than the MMWR policy note that covers more specifically this new expanded adult Hep B vaccination recommendations. And that will be released soon, we think possibly this spring of this year. So now as we think about the application and implementation of these new recommendations, I want to mention here a potential barrier to implementation, and that is COVID-19 fatigue. And of course, I think we are all feeling this because we're all living through this and experiencing this global pandemic together. First, and no surprise here at all, and it's important to note that adults are behind on all of the CDC recommended vaccines. And so significant work to catch patients up to their already recommended vaccine schedules is going to be needed. So the good thing here, though, is that there's going to be a lot of other vaccines being given and plenty of conversations around vaccines and vaccinations in general. Now, second, important for us to understand and appreciate is that providers are incredibly overstretched, as we hear about this in the news and experiencing it firsthand. When I got my COVID-19 vaccine booster in the pharmacy, I could see that the pharmacist was really tired. He ran through the details really quickly. He told me how he was so busy in terms of trying to manage his patient flow. He couldn't even take a break or eat his lunch. Sadly, this is not a unique situation. Providers are overstretched in administering flu, COVID, and COVID boosters. And so it's really going to be really challenging to ensure that they're in the right place to start giving hepatitis B vaccine as these recommendations roll out. So it's also important to recognize, though, that patients may have access challenges. So for example, difficulty in getting in to see a healthcare provider, or difficulty in taking off work, or finding childcare. And then to go see a healthcare provider or have transportation issues are really going to be even more impacted. So as providers start weighing which vaccines to prioritize in each of the different visits, so the more often the patients need to present, the more difficult this is going to be for some patient populations who already don't have good access to healthcare. So lastly, again, really important for us to remember that any education and awareness and all of the uptake efforts around this needs to not only generate a lot of focus in the areas of education and awareness, but also we'll need to break through the COVID noise and the overexhaustion and burnout people feel around COVID-19 vaccines and all the information received on a daily basis. So as we think about implementation of these new recommendations, what are ways we can simplify and streamline vaccination efforts so we can work to catch up adults on recommended vaccinations? How can we make things easier for immunizers and patients? Well, one thing we can do is co-administer vaccines. I know this issue has come up often, so just wanted to take a minute here to talk about co-administration of vaccines. Now, when the COVID vaccines first came out, it was not recommended to give with other vaccines. However, this has not been the case for some time now. So a common question we hear is, can you give COVID-19 vaccine with other vaccines at the same visit? And the answer is yes. Can you give COVID vaccines with Hep B vaccines at the same visit? And the answer is yes. So this strategy of co-administration of vaccines is one helpful way to combat COVID-19 fatigue, but it also helps increase the probability that patients will be fully vaccinated against not only COVID, but other vaccine-preventable diseases. And if you don't know if the patient will come back, co-administration of vaccines at the same visit is an important part of immunization practice. And so speaking of other vaccines, I'd like to now introduce you to Heplessav, which is a recombinant adjuvanted hepatitis B vaccine indicated for adults 18 and older. This is the only 2-dose, 1-month adult Hep B vaccine. This means that patients come for a shot at the first visit, and then 4 weeks later, come back for the second shot, and the vaccine series has been completed. Now, before I jump into the Heplasab specific data, I do need to read through this slide more or less verbatim for regulatory reasons, so just bear with me for a minute here. And by the way, please know that the language on the slide is fairly standard for all of the currently licensed hepatitis B vaccines in the US. So, Heplessav B is indicated for the prevention of infection caused by all known subtypes of hepatitis B virus in adults 18 years of age or older. And here's the important safety information for Heplessav. Do not administer Heplessav B to individuals with a history of severe allergic reaction, for example, anaphylaxis, after a previous dose of any Hep B vaccine, or to any component of Heplessav B, including yeast. Appropriate medical treatment and supervision must be available to manage possible anaphylactic reactions following administration of Heplessav B. Immunocompromised persons, including individuals receiving immunosuppressant therapy, may have a diminished immune response to Heplessav B. Hepatitis B has a long incubation period. Heplessav B may not prevent hepatitis B infection in individuals who have an unrecognized hepatitis B infection at the time of vaccine administration. The most common patient-reported adverse events reported within 7 days of vaccination were injection site pain, fatigue, and headache. Okay, so now let's look at the pivotal trials around Heplessav. So there have been 3 well-controlled head-to-head clinical studies analyzed by the FDA looking at the safety and immunogenicity of Heplessav in comparison to Engerix. So what you are seeing on this slide are the summary graphs for the first 2 of these head-to-head studies. Now I realize this slide is a bit busy, so I'd like to take a minute here to orient you to the 2 study graphs. And I'd like to have you focus on the graph that's on the left-hand side labeled Trial 1. You'll see that the trial enrolled patients from ages 18 to 55. On the x-axis here, you'll see time frame in months. On the y-axis here, you will see percentage of people protected, also known as seroprotection rates. The purple line here represents Heplessav, and the gray line here represents Engerix. Those arrows underneath the x-axis indicates when active doses of vaccine were given. The open circles represent when titers were drawn, and the blue diamonds on the lines represent measured primary endpoints. And so here's where I'd like to make an important reminder, which is unless a facility is checking titer levels after a vaccine is given for all of their patients or employees, which by the way, the majority of facilities across the country do not do, then studies like these are really the best surrogate marker we have with respect as to how these vaccines work after each shot. Okay, so there's pretty much 4 main points I'd like to make for study 1 on the left-hand side here. But you'll also notice that the points I'm going to make for trial 1 will also apply for trial 2 on the right-hand side. So point number 1, the 2-dose vaccine was able to protect more patients in general than the 3-dose vaccine. And so you'll see that a peak of 98% with Heplessav versus a peak seroprotection rate of 81% with Engerix. Now, point number 2, the 2-dose vaccine was able to protect more patients faster as compared to the 3-dose series. So let's look at the 2-month mark here. You can see that approximately 90% of Heplessav recipients have already achieved seroprotection at the 2-month mark as compared to 30% of the Engerix recipients. Now, point number 3 is regarding some conversations I've had with patients and with some healthcare professionals who are under the impression that 1 or 2 doses of the traditional 3-dose Hep B vaccines are good enough. But I can propose to you that the data in these studies simply show that this is not true for the majority of the patients. So if you follow this gray line out here, this Engerix line, you'll notice that the percentage of patients protected does not increase significantly until after the 3rd dose at the 6-month mark. You'll see that where the seroprotection rate increases significantly. So it goes from 33% to 81% in trial 1. And it goes from 21% to 73% in trial number 2. And so this data tells us that if you don't get that third dose of Hendrix into the arm of the patient for whatever reason, then unfortunately many of your patients are left unprotected. And finally, point number 4 is, again, let's follow the gray line out. Even at best, when patients receive all 3 doses, only 81% of patients achieve seroprotection. This means that about 20% of patients, 1 in 5, did not achieve seroprotection. And this is even after completing the vaccination series. So I would ask you to consider what the downstream implications of these data could potentially mean when it comes to an immunization or to your public health policy program. So if you roughly have 1 in 5 people between the ages of 18 to 55 who may not achieve protective titer levels with Hendrix, even after being fully compliant with the traditional 3-dose vaccine series, how many patients are vulnerable to hepatitis B? And in this slide, what we have here are the results from our pivotal trial number 3, also analyzed by the FDA. This again was a well-controlled head-to-head clinical trial looking at the safety and immunogenicity comparing Heplessav to Hendrix. Now, this was an all-comers trial. Looked at persons who are known historically to not respond as well to the traditional 3-dose Hep B vaccine series. And so who are these patients? So these include patients with diabetes, males, older persons, persons with higher BMI, and smokers. So the data in purple represents Heplessav, and the data in gray represents Hendrix. So you can see in the middle of the slide here, these are the persons with diabetes. 90% achieved immunity with Heplessav as compared to 65% with Hendrix. And again, you can see similar results when looking at the table below the circles, and it shows that males, persons with higher BMI, older persons, and smokers have a higher seroprotection rate when given Heplessav, which is in the high 90s, versus those who receive Hendrix, which have SPRs in the high 70s to low 80s. So in other words, more patients reach seroprotection when given Heplessav as compared to Hendrix across these groups. And of course, I can't talk about vaccines without talking about the safety of those vaccines. And so here's some of that information I'd like to present to you now. This slide provides a nice summary showing all the adverse events for the 3 pivotal trials, the head-to-head clinical trials between 2-dose vaccine Heplessav versus the 3-dose Hendrix. And there's really 2 main takeaways for this slide. So takeaway number 1 is unsolicited adverse events, serious adverse events, immune-mediated adverse events all occurred at similar rates across both product arms in all 3 trials. And takeaway number 2, although not mentioned on this slide, but worthwhile to note, is that there were no vaccine-related deaths in any of these head-to-head trials. And now for the last part of my discussion, I'd like to talk about series completion rates. Many of you here, of course, know that when you have more vaccine shots required in the series, the less likely your patients will come back to complete the series for various reasons. So if there's a vaccine series that has 2 doses in a series versus 3 doses in a series, what does that mean? Okay, so let's take a look at some series completion challenges. So I know this slide, again, is a little busy, but the main key takeaway is that there have been several studies showing that patients just have a hard time completing the traditional 3-dose Hep B vaccination series. So prior to coming to Dynavax, I served as Chief of Diabetes for Navajo Area Indian Health Service. And it was quite challenging to get the patients to come back for follow-up visits for so many reasons. Many Navajo people still live in poverty, do not have reliable phones. Many do not have cars, and the res is still quite rural. Many still do not have clean running water or electricity. So it was incredibly challenging to get my patients to come in. I wasn't sure when the next time I would see them really. So if a vaccine has less doses in a series, That means one less trip for the patient, but they can still be fully vaccinated. And so for the sake of time here, I'll just sum up these studies, which looks at patients completing the 3-dose hepatitis B vaccine series. So hepatitis B vaccine series completion rates range from about 22% in the Bridges study to 54% in the Nelson study. So at best, we are only getting just about half of our patients fully vaccinated against Hep B using the 3-dose Hep B vaccine series. Now I'll just go a little bit more in depth into the Bridges study. And of course, this shouldn't be a surprise to anyone on this webinar, since many of you work in immunizations and are probably used to vaccine implementation and know that multi-dose vaccine series are incredibly difficult to ensure that the patient comes back and completes their series. So similarly with Hep B vaccinations, this is the same story. So this is the Bridges studies, which is a CDC-sponsored study, and it looked at close to 30,000 adult Hep B vaccine recipients between years 2012 and 2015. CDC conducted a study looking at at-risk populations in different locations, such as STI clinics, federally qualified health centers, HIV clinics, local health departments. CDC looked at the number of those and percentage of those participants who came in for their first dose, and then how many came back for their second dose, and then how many came back for their third dose. So I'll just draw you to the bottom of this table and to this last row here labeled total. And so if you look at the individuals who start the series, which is about close to 30,000 patients, only about 40% of those came back for their second dose. And not surprisingly, only about 22% of these high-risk patients actually came back for their third dose. And just remember, these are already patients who chose to start this series and are at high risk. And we know that actually getting 3 doses is important for them to achieve seroprotection and to help reduce the impact of hepatitis B, and yet only 22% came back. So as we think about the implementation of these new recommendations, it's important for us to brainstorm on what's it going to take to get our patients to come back in to complete their vaccine series. How do we get patients to commit to this? And how do we follow up to ensure that patients really do come back to complete their series? So we've now made it to the final part of my presentation. And here's where I'd like to leave you with some final thoughts and considerations. So I just want to tie everything together, as we have talked about a lot of things today, and let's boil it down to a few key takeaways. So I hope I have been able to convince you that hepatitis B continues to be a problem here in the United States, with some age segments like those 40 and older are seeing increasing or plateauing of cases. And because we have stagnated in our efforts to decrease new cases, the US government developed a viral hepatitis plan with the goal of eliminating hepatitis B. And this viral hepatitis plan was the push for the new expanded ACIP adult hepatitis B vaccination recommendations. And now that these new expanded recommendations are official, the true work begins in implementing this. So how can we get to a place where we can get the most adults protected against hepatitis B here in the US? What things should we be considering? Well, from the previous data I've shown you, vaccine series completion rates tend to decrease as doses in a series increase. So in other words, the less doses you have in a series, the more likely you'll be able to get your patients fully vaccinated. So compliance matters. So what else should we consider? Does speed to protection matter? Well, it definitely can. The pivotal trials we looked at earlier demonstrate that for many of the patients started on the 2-dose series, on average, they get 5 months earlier protection than those given the 3-dose series. And many patients who started on the 3-dose series will have a window of risk of getting infected while waiting to get their 3rd dose. And the majority of those patients don't see protective titer levels until 1 month after the 3rd dose is given. And what about protecting patients who we know don't respond as well to the 3-dose series? And these patients, again, are those with diabetes, those persons that are older, who tend to be male, have a higher BMI, or are smokers. The previous data demonstrated that the 2-dose series protect more patients that historically hypo-respond as compared to the 3-dose series. And although the information was not presented explicitly today, studies, including a CDC-sponsored study, have been able to show that utilizing Heplessav is cost-effective when compared to NDRIPs. This specific concern of cost was also evaluated by the ACIP when making these recent expanded adult Hep B vaccination recommendations. So my sincere hope today is that everyone tuning in has gained an understanding of the continued hepatitis B problem in the US and can also see that a potential solution is very much within reach with this new expanded ACIP Universal Adult Hep B vaccination recommendation. So by using newer prevention tools like Heplessav, which is a 2-dose, 1-month vaccine regimen, which also, by the way, not only decreases the series from 3 doses to 2 doses, and also provides faster and higher protection rates as compared to the traditional 3 doses, we can hopefully move towards potentially achieving the goal of eliminating hepatitis B in the US. So this concludes my presentation, and I will stop here. I want to thank you all for your time. I know how incredibly busy you all are as we continue to fight COVID while providing routine care for patients. And again, a very deep appreciation to all of you that make sacrifices each day to serve the public, to keep our communities and patients safe. I'm happy to take any questions and comments. Thank you very much.
Thank you, Dr. Huang, and thanks so much. You already have some questions in the chat, but before we get into that, we're going to ask you folks, because we've shared so much information with you, and as you folks know, Vivian and I share a lot of information very quickly. We're going to do a series of 4 polls for you just to kind of remind you just some of the takeaways. So if you could just look on your screen, you're going to see a series of 4 polls come up. So the first one I will read out to you. Actually, I'll read all of them to you. And the first one is true or false. You could administer the hepatitis B vaccine the same day as the COVID-19 vaccine. So please go ahead and answer that. We'll give folks just a few seconds to answer, and then we'll share the result. It bodes well, I think, in terms of the answers that are coming in so far. So maybe we'll just give it 5 more seconds for folks who want to just let us know, true or false, you can administer the hepatitis B vaccine the same day as the COVID-19 vaccine. All right, so I'm going to share the results so you can see of those who answered, you are all correct. I'm so glad you're paying attention. You can administer the hepatitis B vaccine the same day as the COVID-19 vaccine. I'll also note, if you look in the chat, there is a link to a co-administration handout created by the Hepatitis B Foundation. And I know Michaela is here very late on the East Coast joining us. So really props to Michaela and the Hepatitis B Foundation. Okay, so the next question that you folks will see is regarding hepatitis B doses. So, and this should be very easy for you, but true or false, the hepatitis B vaccine series only includes 3 doses over 6 months. Hopefully you will also get this one 100% right. So we'll give folks a few seconds to answer this as well. Maybe a couple more responses and then we will, great. Okay, so I'll end the poll and share the results. Thank you for answering, everybody. So you can see here, the correct answer is actually false. So the hepatitis B vaccine series also includes a 2-dose option, as we just learned about. So thank you for sharing that, Dr. Wang. Our third poll question is around Hep B vaccination in adults. So true or false, the CDC recommends that all adults get immunized for hepatitis B. It's a little bit trickier. Great. I see a spread starting to happen. Thank you for all your responses and for participating. Wow, lots of activity. Okay, great. So I'm going to go ahead and end the poll and just share this with you folks. So there is a spread. We will clarify, right, Dr. Wang, that it is currently the ACIP recommendation is for adults aged 19 to 59. Is that correct?
Yeah, so the adult recommendations are any adults 19 to 59 previously unvaccinated for hepatitis B should get vaccinated. However, for those that are 60 and older, if they have risk factors, they are also recommended to get Hep B vaccination. Now, for those adults 60 years and older with no risk factors, they may get the hepatitis B vaccination.
Fantastic, thank you. And the last one, there is no right answer. So this is just so we can understand what's happening. But in your organization or clinic, are you able to collect data to see how many people need to complete the Hep B vaccine? So this is just for us to know how we can support you folks, especially our local organizations. And I'll just wait a few seconds for folks, give you some time to answer this. Again, there is no right answer. And we just want to get a little bit more understanding of your needs. So maybe 1 or 2 more seconds. Great. Okay, wow, pretty evenly spread for those who answered. So it sounds like a third of you folks are able to see if your clients or patients need Hep B vaccine. About a quarter or a fifth, maybe not, and many of you are unsure. So I think that's a great opportunity. I'll share the results, sorry, for you folks to reach out to me or to any of our partners on this to see how we can help you with that. So really appreciate that. At this point, I'm just going to turn it over. In our last 12 minutes, we'll give time for Q&A, but we'll also want to get some local perspective in terms of what was shared today. So I'm going to reintroduce Joanne Amberg, who is one of our HEP champions, I'll say. I worked with Joanne for many years now. But Joanne, given all the things that we've learned today and all the information, I think the first question that we'll ask, as a local provider working in community health, what are some of the challenges you see with Hep B vaccines for adults? And I think you already posted a few in the chat if you wanted to bring those up.
Thank you, and thank you for having me. I so enjoyed that presentation, and I think Dr. Huang hit it right, right on the nail there. For us, getting folks in for the third vaccine is a huge challenge. I'm mostly involved with perinatal clients, and as such, you would think that, well, we have 9 months to get in all 3 vaccinations. But in reality, at our health center and in other health centers I've worked at, women come in late in pregnancy for their care. And if we test them and they are non-immune patients and offer vaccination, the good news is that most of them are accepting of that vaccination. That's way more than are accepting of COVID vaccination. But the bad news is that when you start your prenatal care in your 6 months or so, it's hard to get in all 3 of the vaccinations in the 6-month regime while you're still pregnant and in some sense a captive audience. So, and then, largely they disappear for a long time. So I think if we could get Heplessav B, and I don't know if there's been a change, but if it was okayed for use in the perinatal community, that would be huge. And I think that would be huge across the border. And the other thing that Dr. Huang also mentioned is just at health centers and that providers face when patients come in with so many needs, getting and scanning the immunization record to see, oh yeah, right, they do need a third, or they do need a second, or they started it, over time is sometimes lost in the shuffle. Else that needs to be covered in a busy visit. So, and with language barriers. And I think, don't know if they were vaccinated before. Most people don't know, in my experience, that they have or don't have hepatitis B. Most of my patients don't even know what hepatitis B is, I would say. So, education is huge, and the simplicity of a 2-dose, not that I'm, the simplicity of a 2-dose regime 1 month apart is huge, I think.
Great, thanks, Joanne. And I don't know, Dr. Wang, if you want to respond to the comment about indication for the perinatal population.
Yeah, so Joanne, you bring up lots of good points. And so right now, I wanted to just make sure everybody on the webinar understands that Heplessav at this time is not recommended in pregnant patients. However, in our package insert, Heplessav B is not contraindicated. So just want to make sure that everybody understands that it's not recommended because we don't have safety data information in the pregnant population. So ACIP and immunize.org have recommended to use the traditional 3-dose vaccine series at this time.
Great, thanks. And Joanne, I'm going to just move us to the flip side of that, which you kind of alluded to in some ways also. But so what are the opportunities that you see with Hep B vaccines for adults, just based on all these kind of updates that you've been provided today?
Well, one opportunity is that there's money out there if you can get it, which if you can change some systems and educate, more staff than the providers, the support staff involved, that there are opportunities, and especially with electronic medical records, to flag charts and, get your whole team involved in trying to make access to vaccination a priority. So we've been trying to do that. We've posted signs, we've educated our medical assistants, and we had some grant money that helped us do more screening and then just more training. And once you start to make those changes, they sound small. Actually, they're not so small. Even just adding new labs into standard routines is a big deal. But once those things start happening, it just those changes really make it easier for all staff and staff coming in to know that this is what we do, and hepatitis B is a priority, and getting the word out there to the providers and the support staff. So it definitely takes a team. It takes multiple ways of reminding people. Just like there are multiple ways that people learn things. So having signs up, having flags and charts, anything you can do to get the team involved in reminding people that they need those additional vaccinations, or to even test for immunity in patients. We've uncovered so many Hep B core positive patients that had no idea that they were core positive, even surface antigen patients. So just offering more testing as a standard of practice. We've done that in the perinatal team and with the perinatal patients, and now we're trying to slowly get that for the rest of the health center as well. So there's definitely opportunities. There's lots of work to be done. There's a lot of opportunities.
Thanks, Joanne. And I'll just note that Joanne and KKV have been fabulous partners. So if you folks want to partner with us or have follow-up questions, please always feel free to reach out to me, and I can always connect appropriately. But I want to thank you, Joanne, for providing some perspective. Always really insightful. We meet once a month on Hepatitis B Project. So I'm going to actually transition to Q&A, and I'll actually start with Joanne's question, actually, that was put in the chat. And then we'll just see what other questions folks have. But Joanne's question was, any studies concerning waning immunity comparing the 2- and 3-dose vaccine? So Dr. Huang, I don't know if you can answer that.
Yeah, so there are no head-to-head studies looking at the 2-dose series versus the 3-dose series at this time. However, ACIP and many other studies have shown that an immunocompetent person that receives their full vaccination series has immunity mainly for lifetime for 30 years. And that's been noted in the ACIP recommendations and also other studies.
Great, thanks, Dr. Huang. The other question was actually from Judy from the Hawaiʻi Immunization Coalition, and that was around insurance coverage. So will insurance cover the cost of the Hep B vaccine series? Do we know yet?
Yeah, so to my understanding, for the private payers, certainly that will be covered. And my understanding with Medicaid is similar. I think what's what may be something that will be confusing coming down the road is for Medicare patients. We believe that those persons will be covered. However, actually understanding the may versus should may have some confusion down the road, but we believe that insurance will cover the 2-dose vaccine series and the traditional 3-dose series.
Thank you, Dr. Huang. Any other comments or questions folks have? Dr. Yamada, I saw you appear. Did you want to say something?
Yeah, Thaddeus, I actually emailed you last night if you could respond. I'm putting together a talk for residents in various residencies that I'm going to give next week on prevention of mother-to-child transmission of hepatitis B, which is a subject that I recall discussing intently with Dr. Huang when we were in Majuro together in 2018. But looking up some of this data, it was 1991, end of 1991, I think, that universal Hep B vaccine in newborns was recommended by Acip, and then in 1995, catch-up vaccination for 11 and 12-year-olds was recommended. And so, I mean, calculating backwards, I mean, that should mean everybody born after about 1983 in the U.S. At the time should have at least been offered hepatitis B vaccination. Obviously, this is, how depends on how good the uptake was of these recommendations at that time and since, because obviously that catch-up vaccination went away. So, I mean, so I calculate that really everybody under the age of about 39 should have at least been offered the hepatitis B vaccine series universally within the US. And so given that we're now going to offer it to everybody over the age, up to the age of 59. So these zero, or I guess for Heplessav, it would be 18-year-olds, but I mean, those zero to 39 years of age, should the routine be to screen with hepatitis B serology before offering the vaccine?
Yes.
That's a great question. And I will just
Yeah.
acknowledge, just in terms of time, if folks have to go, we really wanted to thank everyone who joined us today. If you're able to stay on just a couple more minutes, Dr. Huang, I don't know if you wanted to address that question, but if you do have to go, I really want to just, again, mahalo everyone who made this happen. This is the email in case you folks have follow-up questions. We will be sending a follow-up survey as well as a copy of the recording once that's all set up. So thanks. And if you're able to stay, Dr. Huang, I don't know if you can answer a little bit of Dr. Yamada's question. Thanks.
Yes, so absolutely I can stay. And Seiji, it's really nice to see you again. The last time it was in Majuro. And certainly I think this question has been on all of our minds now. And so, I think, as you said, doing the calculations, persons, ages 39 and younger really should have been offered the vaccination. And, depending on how the uptake has been, really, those persons are already fully vaccinated. So, the ACIP actually recommends that if you can show documentation that there are 3 doses or 2 doses that were given, either 3 doses or 2 doses were given, and they are immunocompetent, then they are considered fully vaccinated. It is not recommended to screen as a initial step when you're vaccinating with a universal vaccination program. So it's really, you really should be vaccinating. And if necessary, you can test in the same visit, but you shouldn't lose that opportunity to vaccinate if you can at that same visit. And so really immunocompetent persons, really if they've already had documentation of 2 or 3 doses, that is sufficient to show that they are fully vaccinated.
Can I add a perspective here? Actually working with the perinatal community. Certainly, from the statistics that we saw earlier in the presentation here in Hawaii with over 50% foreign born, and Seiji, And it's great to see you as well, having worked with you for so long. You know, so many of our patients are non-immune. So many of them, they don't know if they've been vaccinated. They come from elsewhere. And even people, and we have had that even in our KKV records, that was what was my question about the waning immunity, because we have documented people that were vaccinated, and maybe it's a very rare thing, but we have had documented 3 shots hepatitis B in the chart. They were pediatric patients, and then they come out non-immune. So we're testing everybody with the 3 surface antigen, core antibody, and surface antibody to get their status. We're informing tons of people about their core antibody status. We're finding certainly surface antigen is a standard Hawaiʻi obstetrical lab in the perinatal panel. And, you know, because you want to decrease that transmission, and, you know, it might be the case that viral counts are high and they need some tenofovir later in the pregnancy. Based on that, we're screening. That's a standard thing. But, you know, Seiji, it's been a great thing for us to do that. We found so many non-immune folks, and that's what's prompted our vaccination rate has doubled since we started doing that.
Thanks, Joanne, for the perspective. And I'm actually I know folks are telling me that they have to leave. So I'm gonna just do the last question from Michaela, since she did raise her hand. Michaela, did you want to ask a final question before we close out?
Oh, I don't have a question. I just wanted to quickly say, in terms of that, just wanted to make people aware that I know this is an immunization conversation, but the CDC is working on screening guidelines, updating their screening guidelines as well, and that should be coming out sometimes this year. So I know we get that question a lot at the Hepatitis B Foundation as well. And obviously, I'm not a provider, so I defer to the providers for their clinical guidance, but that just might help clear some things up as well down the line.
Thanks so much, Michaela, for the federal perspective. And Michaela, again, works for the Hep B Foundation, which is global and national Hep B work. I do want to thank Dr. Huang, Dr. Yamada. I will email you soon, Joanne, and everyone who made this happen. Thank you for staying about 5 minutes over. I'm really excited to move forward. We will have other sessions like this coming up, especially after the MMWR is released from the CDC on this topic. So please stay tuned. We'll send you a follow-up email very soon. And thanks again. Have a great afternoon, everybody. And thanks for staying on a little bit longer. Take care.
Everybody.